Now, the health department is adamant that its decision to vaccinate children aged between 12 and 17 is within the law, saying it's concerned that members of the public are blowing their fears out of proportion. The Children's Act says in part, a child may consent to his or her own medical treatment or to the medical treatment of his or her child if the child is over the age of 12 years and the child of sufficient maturity and has the mental capacity to understand the benefits, risks, social or other implications of the treatment. Government has extended its vaccine rollout program to children in this group with effect from today. But the issue of consent has stimulated fierce public debate. And to talk to us more on this, we're joined by international vaccine expert and chair of the South African Health Products Regulatory Authority Board, SAHPRA, Professor Helen Rees. A very good morning to you, Professor Rees. Thanks for making the time.
Good morning. Thank you for having me.
The health department saying that the public responses are exaggerated. What are your thoughts?
Well, I think that with all matters to do with COVID vaccines, that there are understandably nervousness, questions, hesitancy, which I feel that as clinicians and scientists, we should do our best to answer. So once you move into adolescence, I think it's very understandable that parents and young people will be saying, well, is it safe? Will it work? What does it mean for me? And they'll have a lot of questions. So from my perspective, I think that what we need to do is to answer those questions and to reassure parents and caregivers and guardians, and also the young people who are thinking about having the vaccine.
Just in terms of the drugs, what are we learning about the antiviral pill, molnupiravir, produced by U.S. pharmaceutical company Merck as a possible weapon against COVID-19?
Well, this is exciting. What we're waiting to see is the published data. But what we've heard so far from Merck has great potential. This is a drug that you can take for a few days, just tablets twice a day. So it's easy because it's an oral tablet. It's not a drip, nothing like that. And it's for people who've got early signs of infection. And what they found was that by taking this tablet, they reported that hospitalization and deaths were significantly reduced. Now, the exciting thing about this is that if we can turn COVID-19 into a less serious disease and a disease that causes less fatalities, then we are going to be able to get on top of the pandemic from a different direction to that of vaccines. Vaccines will prevent, but this will really help us treat and will stop people getting into hospital. The big question, though, for countries like South Africa, for the African region, is whether we're going to get access to this drug, because we do know that so far, for example, the United States has purchased 1.2 billion doses, I think. And I think the concern for low middle income countries is that we're once again going to be left out of something that has a really possibility of having a big impact on the pandemic.
The other conversation about the fight against COVID-19, we're now down to alert level 1. We have an election coming up. When you consider the current COVID numbers and factors in gathering under level 1, what does Christmas look like in terms of case numbers?
Well, I mean, that's the million-dollar question, and we all hope that we're going to see the low numbers that we're seeing now. But I think generally we are concerned that we could have a fourth wave. And the things that will sort of precipitate this fourth wave will be things such as low vaccination coverage. We need to get our vaccination coverage up for all our target groups. We're talking a lot about adolescents, understandably, because this is the first day of offering to 12 to 17-year-olds. But we want to get our coverage up for our high risk, our 60s and over, but also we're seeing that the 30 to 40-year-olds low uptake. So that will be the first thing. The second thing is that we need to continue to be very cautious. I think South Africans have understood and taken some of the messages to heart, including mask wearing, distancing, sanitizing, ventilation, but we can't stop doing that yet. And if social behavior changes because of the low numbers now, now, then we're setting the scene for another wave. And the third real unknown is whether we get a new variant. I think by now everyone's familiar with the fact we had the Beta variant at the end of last year, and now the Delta variant, which caused this huge, steep third wave with large numbers of hospitalization and a high transmission rate. If we get another new variant with unknown transmission, we won't know. We can't predict that, but that could make a fourth wave more likely. So all of those things are very important. And one way to stop that variant emerging is to get vaccination coverage up. So a lot of things come back to the need for high vaccination coverage.
Just a detail about the cohort that's starting today. For the longest of time, the Pfizer vaccination was a 2-dose vaccination, and we're talking about 1 dose for the 12 to 17-year-olds. Unpack this for us.
Well, this is something that's been done in other countries as well. So young people have a very good immune system. As you get older, like everything else, your immune system weakens and its response to vaccines also weakens. But young people have a good immune system. So they are likely to have a very good response to a single dose. And we do know generally for all populations, all age groups, that a single dose of vaccine does give some level of protection, but a second dose will do more. But the reason why we're doing this at the moment for young people with a single dose is we're being cautious. There's a very, very rare side effect that's been observed mostly in young men in their 20s. It's observed in the US and other studies as well, where you get inflammation of the heart muscle. It's extremely rare. And inflammation of the heart muscle also occurs in COVID-19 disease. It's 18 times more common in someone who has COVID-19 infection than somebody who doesn't have an infection. So this is a risk of the disease, and it's an extremely rare risk associated with the vaccine, but tends to occur more after the second dose. So because of that, we're giving the first dose first, getting some protection. And remember, many of these young people who've been at school, been in doing sports and so on, might well have already had an infection with COVID, in which case that single dose will give them a real boost of protection. But we believe that that will protect young people partially, and then we'll decide later on whether to come back and give that second dose. And a longer interval is not a problem for the Pfizer vaccine because it performs well if you have weeks or even months between the first and second doses.
Another conversation that's currently underway is the reports that Pfizer says its vaccine is safe for children aged 5 to 11. They say it shows a robust antibody response. What's SAHPRA's thoughts on vaccines being administered to children in this age group?
Well, I think that over time, it's something that's very likely to develop. And we know also that Sinovac is doing studies on children as well. In fact, many of the vaccines that are out there and being distributed are now also looking at lower age groups. Over time, we don't know what will happen to this virus, but one of the likely scenarios is that we'll have to live with it. We're not going to be able to eradicate it. We'll have to live with it. And it's quite possible that it might become like influenza, like flu, that it'll become possibly seasonal, and we'll know that we're going to have outbreaks. In which case, we're going to want to protect all age groups with this. We also don't know that if we get a new variant that we might see something that could cause more harm in younger children. So we want to be fully armed in case that occurs. So it's very important that we explore now the safety, the effectiveness of these vaccines when they're given to younger age groups. And in the future, depending on how this current pandemic goes, depending if there are other variants, depending on what we see, we will then be able to choose or not to choose to give to younger children, depending on the situation that's affecting the community.
We've asked this question in our previous conversations, but viewers asked so much about this so that we need to reiterate the potency and effectiveness of the vaccine against COVID, especially when someone is also battling other diseases at the same time and is also at an advanced age.
Yes, well, some of the diseases that we worry about are the diseases that cause what we call immunosuppression, things that dampen down your immune response. And so we know that in that group that the vaccines are likely not to perform as well. In addition, sorry for the phone. In addition, we also know that as people get older, that the immune response is also dampened down. So for these groups, what people are looking at is now giving a booster dose. For the people who've got immunosuppressive diseases or immunosuppressive drugs, that we're now recommending that they would have an extra dose of the vaccines that we have. And in some countries, in older people, where their response to the vaccines is not as good, they're giving a booster dose. Now, we're not doing that yet. In South Africa, our perspective is that we want to get coverage up first. That's the first priority. We want to get as many people as we can. You know, the ambition is to get 70% of the adult population immunized by the end of the year. Now, we've slowed up. That's going to be difficult to achieve unless we can have a huge effort to try and reach out to people. But in the future, we are recommending now that people who have got immunosuppressive conditions could have an extra dose. And we're also exploring that for people living with HIV. And the Ministry of Health, the Minister of Health and the Department of Health are looking at both of those matters.
In fact, just staying with the same conversation, you may or may not want to respond to this question, but one of the big stories, international stories this week, was the passing of the America's former Secretary of State, General Colin Powell, who was reportedly died of complications related to COVID, had fully vaccinated, but also was dealing at the same time with issues related to cancer. What sort of conversations are being held here?
Well, remember that none of the vaccines we have, none of them at all, are 100% effective. So we are going to see some people who will become infected having had a vaccine. But we do know that all the vaccines that are currently out there, both in South Africa and globally, reduce severe disease and hospitalization. So it's not surprising that we will get people who have had the vaccine and will get infected. It's very sad to hear about Colin Powell, but he was over 80, and people over 80, as we've just said, don't respond as well to the vaccine and are more vulnerable to infection and more vulnerable to severe disease and death, sadly. But in addition, he had a condition which also affects the immune system. So the disease he had affects the immune system, and very likely, although we don't know this, some of the treatment he may have been receiving for that disease could have also dampened down the immune system, and all of that would have made him more vulnerable to severe COVID infection.
So basically, cases should be dealt with on an individual basis.
Yes, and certainly I'm sure that people, for example, the people who treat cancer patients, the oncologists, are doing just that. And as I say, for us, a very important population, because that we have so many of people in our community who are living with HIV. This is an important group as well. And for that group, the very important thing is to get onto antiretrovirals and to control the disease, because that boosts the immune system and that helps to protect people. So that's a community that we're also thinking long and hard about, and we must make sure that we continue to keep our HIV services going, keep people in care, and to keep their diseases well controlled.
And finally, just to this group that's going out to vaccinate today, what sort of how do we control their expectations in terms of how they can react to the vaccine?
Yeah, well, in fact, I've just come from talking to Jeppe Girls High, and we talked a little bit about exactly that. You know, what are people thinking? Are they anxious? Do they have questions? So, their expectation, I don't think they shouldn't be scared. Most people, the vaccine itself is you get a little prick in the arm. Everyone will have had an injection at some time, so it's the same thing. And you get a prick in the arm and a momentary soreness. But because they're young and they've got a very robust immune system, they might get these side effects that are transient. They might feel tired. They might get a bit of a fever. They might get muscle aches, headaches. These are things that people not uncommonly report, and it's because your immune system is responding, and they're self-limiting. They usually go away in a couple of days. So from that point of view, they can expect that. But really encourage young people to do this. I mean, young people it's taken a toll on young people's health, on teenagers' health. You talk to anyone who's got an adolescent, a time when they should be out really hanging out with friends, making new friends, getting boyfriends, girlfriends, and so on. I mean, they've been stuck. They've been stuck at home for a very long period. We want them to have an opportunity to have some sort of normality, which vaccination will help them achieve. And to allow them to really to contribute to restoring mental health in these age groups.
Of course, there's lots to talk about, just time constraints, but thank you so much for making the time this morning.
Thank you very much.
I was international vaccine expert and chair of the South African Health Products Regulatory Authority, Professor Helen Rees.